Welcome to the Clinical Podcast Series brought to you by the American Academy of Optometry Foundation. Today's episode is entitled Association of Predominantly Peripheral Lesions on Ultra-Widefield Imaging and the Risk of Diabetic Retinopathy Worsening Over Time. I'd like to thank our topical editor and host today, Dr. Andrew Rixon, our topical expert, Dr. Jim Williamson. And now it's my pleasure to begin today's podcast.
Good evening. My name is Drew Rixon. I'm the topical editor for this AAOF podcast. Our subject matter is going to be glaucoma and retinal care. I'm also going to be the guest host tonight. And joining us tonight is our content expert, Jim Williamson. And he's going to be covering first association of predominantly peripheral lesions on ultra-widefield imaging and the risk of diabetic retinopathy worsening over time. So Jim, let's just jump right to it. What made you choose this article? Like, what's the relevance to you?
Well, I think most of us, when we dilate our patients and we get out our 90Ds or 78s, we do a cursory look. We'll look at the nerve, we'll follow the arcades, we'll look at the macula, but we sort of fail to think about the peripheral retina and diabetes and assessing that for risk for progression. The Arley House Symposium, 50 years ago talked about the retinal periphery as far as, being able to evaluate to assess for risk. So I think that's something that brought me to this article.
Great. Yeah, I definitely think it's a paradigm shift because I think when I was training, it was really more of a posterior pole centric sort of thing. So what's the relevance to us in practice? What are the findings of this overall study here, and just kind of break it down for us, please?
Yeah, so Dr. Cavallorano, who's one of our own, about 5 or 6 years ago, I think he was second author on this study. He talked about these, and I think they coined the term predominantly peripheral lesions, where the presence of these lesions increase your risk for not only progressing in diabetic retinopathy, but also progressing toward neovascularization. So along those same lines, this AA study looked at ultra-widefield photographs of about 400 participants that were 18 years of older. They were either type 1 or type 2, no center-involved DME. And over that 4-year period, they did ultra-widefield color photographs. But along with that, they also did an ultra-widefield fluorescein angiography at the first year and the 4th year. And so their primary endpoint was, do these predominantly peripheral regions give us a good look at risk for progression? And they looked at these lesions as being either microaneurysms, intraretinal hemorrhages, venous beating, IRMA, or neovascularization.
Great. And so, a lot of us have incorporated ultra-widefield imaging into our practices, especially with our diabetics. So essentially what you're saying is that they found kind of biomarkers that would be available without having to do angiography, because a lot of us are not doing that helped kind of predict. Is that what the findings were?
Yeah, so it's interesting. They had a masked and unmasked part of the study where they took the ETDRS grid, because they used the DRSS, or the Diabetic Retinopathy Severity Scale. They used the DRSS to grade these photographs. And what they did is they had the reading centers masked to only be able to see the ETDRS areas. And they did an unmasked grading as well, where they took away that mask and then they looked at these predominantly peripheral lesions. And it was interesting, they did not find an association between color photographs and risk for progression, but they did find an association. It was about a 2 times risk for ultra-widefield fluorescein angiography and risk for progression, which was interesting.
Okay, so that does kind of limit our applicability a lot of times in practice. I guess that was a limit with the difference between the color and the fluorescein. Were there any other limitations that you think would prevent us from employing this in practice that you found?
I think just talking about fluorescein angiograms, and I know you do those, I do those as well. It's interesting to see how many times we will look at an area on the retina and look, hey, looks like NVE. Let's go ahead and do a fluorescein angiogram and make sure. And then all of a sudden there's 4 or 5 areas of NVE that light up. So I think that the fluorescein was interesting only because I think it does capture those areas. Then they even showed it was capturing MAs maybe 3 to 5 times more than what a color photograph would do. But I think for me, the big thing is that in that study, they were just looking at the color photographs. So, those of us that are involved, you as well, that are involved with ultra-widefield, when we're looking at the photographs, yeah, we'll look at color, but on the lines of a fluorescein angiogram where you have that high contrast, a lot of us will use the filters in our ultra-widefield machines to be able to apply, say, the red-free filter, where we're looking at the retina, the inner retina, where it highlights those diabetic changes a lot better to me than it does when you're trying to find those subtle microaneurysms or subtle diabetic retinopathy changes in an ultra-widefield photograph. So I think that was one of the things in the study I think could have been a fault, was they just did the stock colored photograph and that was it. They didn't allow the examiners to manipulate the images at all, whether it be multispectral or just in contrast.
Right, tremendous. A really, really good summary of that article, and I think it's definitely something that our fellow fellows, ironically enough, was actually really, really benefit from looking through. So, really appreciate your time on that, Jim, and your expertise. So everybody go and check that article out. The link will be below. Thanks.
Thank you.
Okay.
And a special thanks to CooperVision for their educational grant to make it all happen.